Well, I think we can go ahead and get started. Good afternoon, everyone. On behalf of the Center for Engagement in Diabetes Research, or CEDER, I'm really pleased to welcome you to today's learning exchange on partnering for health across the diabetes spectrum, best practices in community-engaged type 2 diabetes research. My name is Nadia Islam. I'm a professor of population health at NYU School of Medicine and one of the principal investigators for CEDER. I'm really happy to be joined by Dr. Miranda Brodney, who is a program director at NIDDK. And at this time, I'm going to turn it over to Dr. Brodney.
Thank you, Nadia, and welcome everyone. We're really excited to have this learning exchange today. You can see the agenda posted on the slide. After our brief overview and intro, we're going to move into best practices with a full panel of investigators, both academic and community-based researchers who have best practices in community engagement that they are doing across their team that may be applicable and translate well to type 1. And then we'll have a Q&A session held at the end before closing. You can go ahead and advance. So NIDDK is very excited and enthusiastic to support engagement innovation in clinical diabetes research. I am here as one of our working group members across engagement in the Division of Endocrine Metabolism and Metabolic Diseases. You can advance. So we thought it might be nice to open the stage with a pause to get everyone's frame of mind in thinking about the similarities and differences between type 1 and type 2 diabetes. On the left, we'll start with population similarities. So disease management is a first one that comes to my mind when thinking about the two populations. Everyone living with diabetes mellitus has to know what their sugar level is, their glucose, on a daily basis, how much they put into their body and what their level is. They know this. So there's a similarity there in how they manage their disease. Also, disease morbidity and mortality, unfortunately, is similar across the two in that they both have these very severe outcomes when things don't go well, both limb and life-threatening, and comorbidities in additional organs throughout the entire body can be impacted, including mental health, and that is similar across the two populations. In looking at the disease populations, there's also similarity in that there's heterogeneity present in both. In type 2 diabetes, there is a heavier presence of racial and ethnic minority backgrounds. However, both have a decent amount of heterogeneity, and that's similar. And finally, there are health disparities present in both populations, from health literacy to rural and urban type populations, racial and ethnic populations. Just to name a few, there are health disparities in whose outcomes are doing well and whose have room for improvement. And that's a similarity across the two. Moving to the right column, looking at population differences, which may be of note when we're thinking about how to translate best practices and engagement from type 2 to type 1. First, the disease onset is peculiarly different and may impact how your engagement and your population are when thinking about the two between type 2 and type 1. The pace of onset, the time between the first symptom onset and full-fledged diabetes in type 1 is very short. And this is very different than type 2, where the onset of clinical symptoms and the length of time it takes to have full-fledged diabetes, maybe a couple of days, maybe months, or even years. So that really creates a very distinct, different subpopulation in the type 2 realm compared to type 1. And of note, that is a level of, or a subpopulation that has a level of preventability that's present that is not present in type 1. Disease management, I said there are similarities because they're both following glucose. However, there are differences, as many, if not all of the audience are aware, in the medications. The core medication in type 1, of course, is injectable insulin, and not all populations living with type 2 are reliant on injectable insulin, and that can be a key difference of your population. And looking at differences in the disease population a little bit more closely, from a global epidemiologic perspective, there is decreased numbers of type 1 present overall. a fraction, maybe a tenth or less. So that means the capture and the accessibility of people living with this disease is smaller compared to type 2. And there is less heterogeneity in type 1 with decreased minority presence in type 1 compared to type 2. However, not zero, as I mentioned before. So those are some of the key similarities and differences to keep in mind when we're thinking about how we might translate the best practices we're hearing about today from the type 2 space to the type 1 space. You can go ahead and advance. So why is stakeholder engagement and participation from the community important in type 1 diabetes? Type 1 research significantly lacks the voice and participation of all individuals impacted with this disease. As just one statistic, a recent review and data from 2021 indicates that the US population prevalence of individuals living with type 1 who identify as non-Hispanic Black is approximately 9%. And in the same time frame, or the recent time frame, the last 6 years, the clinical trial participant representation of the same population was only 2%. So we can see that we're not including and engaging a representative sample. Advance, please. Additionally, type 1 diabetes gaps in care, which are related to health disparities, are highly present. One example and a statistic to support that is that continuous glucose monitoring use has been identified to be lower in rural youth living with type 1 compared to urban dwelling youth. And that's just one statistic. It's very recurrent identification of the health disparities and gaps in care. So we really assert that the following critical needs are quintessential as we hope to improve type 1 outcomes for all individuals. Meaningful stakeholder participation with type 1 diabetes clinical studies, improved recruitment and retention of people with all backgrounds in our studies, and multidisciplinary type 1 investigators with expertise in community engaged research. In advance. In conclusion, NIDDK supports increased breadth and depth of community engagement in all of our mission diseases, and today, including type 1 diabetes. That is why we're bringing everyone to the table. All right, Nadia, I think you can take it from there.
Wonderful. Thank you so much, Dr. Bodney. So what I'm going to do is give you just a brief overview and a little bit of history on the formation of National CEDER. It's a brief history, but builds on decades and decades of expertise and engagement in community partnerships and community-led research. Next slide. So CEDER is a little bit different than many of the other projects in NIDDK's portfolio because we are not a research center. What we are is a center that provides resources and technical assistance to promote engagement in diabetes-related research and programs. So we certainly have a goal of advancing type 2 diabetes-related research, but we do that by leveraging our expertise across a large national network of community, academic, and other multi-sector partner, again, to provide resources and technical assistance. And I'll, on the next slide, show you exactly what those are. Actually, but you can go back to the last slide, because I wanted to spend a little bit of time talking about how our goal is very much grounded in a vision of fostering both community-led and community-informed diabetes research. And I think that's very important. When we think about community engagement, we often think about partnership between academic and community partners, but often the ideas for the research come from academic partners. And what I think we've seen over the last few decades is that there is a movement to really foster community-led research. Who better to understand the issues, challenges, strengths in our communities and community members themselves, and why shouldn't they be having a role in leading our research? And so for CEDER, we really hope to foster both community-led as well as community-informed diabetes research for all communities by integrating multi-sector engagement across the research spectrum. Now you can go to the next slide. So we provide two specific types of services: consultations and studios. And consultations are straightforward requests that we take from clients where one or more experts provides feedback, advice, mentorship, or training on specific diabetes-related research study or program. A consultation can include things like sharing resources, providing a review of grant proposals or an IRB application, or connecting clients to other experts in the field. And they're typically brief and time limited and can be conducted through a variety of channels. CEDER is a national center and we are a virtual center. We conduct the majority of our work virtually. Consultations can lead to studios, which are the other type of service that we provide. Studios are longer, more structured opportunities to receive feedback and advice from a panel of experts on questions related to specific diabetes-related research or programs. This can include recommendations about project or study design, implementation strategies, program or project materials, translation, cultural adaptation of interventions or curriculum, and dissemination of findings. And as I mentioned, studios are typically more time intensive. They may involve more than one session. Now, what's really important about the way we've designed CEDER services, you could see at the top who can request services. Our consultations and studios are designed to be of use to researchers, but also faculty members, patients, caregivers, healthcare providers, and individuals from community-based organizations. So, for example, if you are a CBO that has a lot of client data on food insecurity, and you're interested in using the power of that data to inform policymakers on the importance of particular policies, you can come to CEDER and we can provide consultations or studios on how to analyze that data, how to disseminate it in ways that are compelling. If you're a researcher who wants to implement a culturally adapted diabetes prevention intervention in the Latino community in a specific area of Florida, we can connect you to our colleagues and partners there to help you connect with community-based organizations, understand their needs and assets, and how to incorporate those into your study design. So we really, through our client base and our structure, try to foster bidirectional research. Next slide, please. So partnership is really baked into our structure at every level of CEDER, and that stems all the way from our leadership. So our CEDER, as I mentioned, I am one of the PIs of CEDER. I'm joined by MPIs Arlene Brown at UCLA and Earl Chambers at Einstein School of Medicine. Each of our cores is also co-led by representatives from community-based organizations, including Health People, which is a diabetes advocacy organization based in New York City, Visión y Compromiso, which is a navigator and promotora organization in California, and the American Diabetes Association, which is a national trade association that has a leading role in advancing diabetes-related advocacy as well as education and training. We also, as you can see from this map, are a partnership of over 18 community and 18 academic organizations and 10 regional and community-based organizations. This is why we call ourselves a national resource. We were intentional in including both a community and academic partner at each of the sites we engage, and you can see those sites here on this map. And in that engagement process, we have included experts who have a strong history of community engaged research in type 2 diabetes across diverse populations. In this way, CEDER provides geographic reach and opportunities for collaboration across the country in rural and urban areas with communities disproportionately impacted by type 2 diabetes disparities. And in fact, you're going to hear from many of those experts and members of our partnership hub today. Next slide. So with that, I will turn it back to Dr. Brodney, who will go over the purpose of today's learning exchange.
Wonderful. Thank you, Dr. Song. So the overview of the learning exchange today, goals are listed here. We are hopeful that you will hear the shared examples of best practices of positive research community partnerships that highlight community engagement in type 2 and programs in all communities, and that you'll have an increased understanding and expertise around policy, communications, grant writing, community-based participatory research, and other associated topics. All of the participants, yourselves, oops, will you go back for a second? We have hub members and clients in the virtual room, if you will, and many investigators across type 2 and type 1. And we're going to go through cases today. You can put questions in the chat. We'll hold a full Q&A at the end, but we may have time for one or two at the intersection between each individual presentation. Okay, you can advance. All right, so the speakers today are on the screen. We have a really rich group of investigators from academic centers as well as community organizations. We have Darius Tandon coming from Northwestern University School of Medicine, Kristen Allen Watts coming from UAB with a couple of team members, I believe, Felicia Barrow coming from Connection Health, Lou Hu from NYU Grossman School of Medicine, Marilyn Roman, Miami-Dade Area Health Education Center, and Guillermo Alvarez coming from the Latino Health Access Organization. I'm not going to spend a lot of time on the intros, so I announced everyone now, but we're just going to move smoothly through all of the presentations. Okay, you can advance. Believe. We'll go ahead and skip this. We need to get into the talks. Thank you. All right, so the first talk by Darius Tandon is Best Practices in Community Engagements. Go ahead and take it away.
Thanks, Dr. Bradney. Really lovely to be here today to share a little bit around best practices in community engagement. And let me just preface by saying, I only have a few minutes and I'm really sort of the opening act before you hear a lot of wonderful case examples. So in my presentation, I'm going to really try to highlight some sort of key principles, some key practices, but you're going to hear how a lot of those best practices are really being operationalized in the case studies from the later presenters today. Next slide, please. Next slide.
It's like we might have a freeze.
Yeah. Sorry, let me load the other slides. Apologies. Let me share. Thanks, Sarah. Sorry about that.
Awesome, thank you. So probably good to start with a definition. There are a lot of definitions of community engagement. This is one that I like: collaboration between institutions of higher education and their larger communities for the mutually beneficial exchange of knowledge and resources in a context of partnership and reciprocity. So that mutually beneficial exchange of knowledge and resources, right, is really the hallmark of community engaged research. Next slide, please. Couple things that I think are important to highlight: that community engagement is an orientation to research, right? It is not a research method. It is not a research design, right? We can use a variety of methods: quantitative, qualitative, mixed methods, a variety of research designs, RCTs, observational studies. So really important to think of, community engaged research as an approach or a paradigm or a way of doing business. There's been a lot of growth in community engaged research. So I've been doing this work for a couple of decades now. And I remember giving talks, almost clandestine 2 decades ago about this thing called community engaged research. So we have generated a lot of evidence around what works. And so what you're going to hear today from me, and then more so from the case examples, the presenters, are going to be a variety of topics focused on who should be involved, how to maximize community partner engagement, and also hearing some examples about ways in which stakeholders and where stakeholders can provide valuable input. Next slide, please. So when we're talking about stakeholders, and I do have an asterisk because I know that the term stakeholder is one that many of us, including our center at Northwestern, are starting to shy away from a little bit because of some of the connotations associated with it. I will continue to use that phrase today, but I may use the phrase partners or constituents interchangeably. So who are partners or community stakeholders? They are individuals or groups responsible for or affected by health and healthcare related decisions. Tom Concannon, about a decade ago, put out a really nice article that was a taxonomy of different stakeholders. They all start with the letter P: patients, providers, purchasers, payers, policymakers, product makers, and finally PIs and other researchers. Now, not all of those individuals are going to be involved in a given project. And so as you're thinking about which partners would be involved, here are some considerations: the funder requirement, the objectives of the project, the type of input you need, and when you need the input, right? Because input might look different pre-award, during the project, and post-award. And importantly, and this is the last bullet point, when possible, to try to bring in perspectives of multiple stakeholders, because we know that the perspectives that patients and providers have might be very different. And so if you are only bringing in one viewpoint, that might be limiting in the perspectives you're trying to bring into your project. Next slide, please. So thinking about how to maximize stakeholder engagement, and this is where we start to get into the best practices. And again, I'm not going to go into a lot of depth or give a lot of examples because you're going to hear those in the subsequent presentations. But what are some things that are important in terms of maximizing stakeholder engagement? So first, being very clear. What are the roles and responsibilities of your stakeholders, right? So as we're writing our grants to NIH or CDC or private foundations, we need to justify, right? And we need to write up what we as academic investigators are doing, right? What's a description of our role? The same thing is true for our community partners. We need to be specific in terms of what they will be contributing to a project. Clearly articulate what our stakeholders will gain, either as an individual or on behalf of their agency, right? So our stakeholders have so many demands on their time, much like we have demands on our time as academic partners. So why should they be involved? What is the benefit that they're going to gain? So a couple examples: for patients, it might be promoting access to new treatments and therapies. For providers, it might be to determine more sustainable models for implementing healthcare. And then once you have articulated those roles and responsibilities and how stakeholders are going to benefit, really put those things on paper, right? So develop those sound bites or materials that you can actually use to recruit stakeholders, and those really should be linked to those first two bullet points. Next slide, please. How do you sustain stakeholders when you have already recruited them? Well, really important, really at the onset of a project, to provide clarity on how stakeholder input is going to be used. So the one thing that we don't want to have happen is for you to be trying to get insight, perspective from community partners, only to tell them, oh, well, we can't really use that input, right? So being clear on things that are flexible and also things that are not flexible. And then also being clear, what exactly are stakeholders going to be doing? Are they advising, and ultimately investigators will be making a decision? Or are they really going to be sharing in governance in terms of making decisions on a project? Really important to also make sure that all partners understand key aspects of the study. So providing stakeholders with details on the objectives and aims, timelines, and milestones. Developing processes that acknowledge different ways of communicating. So be open to different models of communication, depending on stakeholder preferences. Ensure that the content that you're sharing with partners has clear and accessible language, and also provide space for stakeholders to point out when they need more clarity on what a project is focusing on. And then finally, and I think that this is, even more salient, in the environment that we're currently in, recognizing that your community stakeholders, your community partners, are affected by many social, political, and economic factors that might input their ability to engage in a timely fashion with you. Next slide, please. Couple slides about partnership functioning, and I know that there are going to be some examples of this given later on as well. So many of us often create community advisory boards to guide our projects. And for those of you who do, what are some things to think about? What are some some key considerations. Really important to talk about how often the CAB will meet. Are there minimum requirements for who would be part of the CAB? Can folks join by phone? Is this going to be a hybrid, CAB, or are you going to provide options for folks to be in person? Where will the CAB meetings take place? When? How long? Do these need to be rotated over time if they're in-person meetings? Are subcommittees needed? How are they going to be led, and how are they going to report to the larger group? Next slide. And then in terms of partnership functioning, leadership, right? So very important to have clarity on how the partnership is going to be, or how the CAB is going to be led. So we often suggest recruiting a chairperson or co-chairs, including a community co-chair, to lead the advisory board and to work with administrative leadership, and then also recommend a co-chair structure for subcommittees. Next slide, please. So a couple more slides, and these are really just sort of highlighting very, very sort of rapid fire ways in which, places in which community partners might be able to provide input related to a project. So related to improving study design, providing input on key comparators, related to ensuring patient-centeredness of study outcomes, also helping to determine data collection procedures. Next slide. Related to facilitating recruitment and retention, this is a place where community partners can advise on a variety of topics, including where recruitment should take place, who should be conducting recruitment. That third bullet point is one that I always emphasize, right? When we are doing studies, whether they're clinical trials or other types of studies, what's the first thing a study participant sees? It's oftentimes those recruitment materials and consent forms. So really making sure that we're getting community input on how to make sure that the language and terminology in those materials are going to be accessible and understood. What are incentives that will keep participants engaged? What are barriers to enrollment and retention? And finally, are there community stakeholders that might be able to serve as liaisons who could destigmatize study participation? Next slide. And for those of you who are doing intervention work, again, ways in which community partners, constituents can provide value, thinking about best time and location for interventions to occur, understanding what experience does a community have with previous interventions? How does local culture or capacity influence the way in which an intervention is going to be integrated and delivered? And then also thinking about skills and experiences that are needed to deliver programs, services, and interventions. And final slide, please. So just a slide on a couple of closing thoughts. So engagement is on a continuum, right? So, again, without more time to sort of talk about that today, right? There might be ways in which you are getting input, but ultimately academics will be making decisions, but then there may also be more sort of shared governance. So really being clear on where on the continuum of engagement your project is going to fall. And recognize that some of your partners, right? So those of you on the webinar today, you might be very comfortable with a community engaged approach, but recognize that many faculty and academic partners might be less comfortable with giving away some control. And so you might need to be sharing presentations like the one that you're hearing, from today, with those partners so that they're becoming more comfortable with ways in which partners, can provide input in a community engaged project. And then finally, reiterating the point about valuing the engagement of a diverse set of stakeholders. So with that, those are some sort of key considerations, best practices at a very high level. And now we're going to transition to a series of case studies that will provide a lot more meat and examples around some of those best practices.
Excellent. Thank you so much, Darius. All right, so we'll move into the case series now, looking at lessons learned from Type 2 partnership development. And our first presenter and team, you can go ahead and advance, is Dr. Kristen Allen Watts and her full team listed here, coming from UAB and their partners. So go ahead and take it away and introduce yourselves some more if you would like to.
Sure. Thank you so much, Dr. Brodney. So good afternoon, all. My name is Kristen Allen Watts. I am an assistant professor at the University of Alabama at Birmingham in the Division of General Medicine and Population Science. My research largely centers around how individuals manage diabetes-related comorbidities, and I am here today with my colleague from Connection Health, Felicia.
Good afternoon, everyone. Thank you so much, Dr. Alan Watts. My name is Felicia Barrow. I am the Director of Operations with Connection Health, and Connection Health is a nonprofit in the Birmingham, Alabama area, and we work with or allow engagement. We foster the engagement with community health workers in our organization. So glad to be here with you.
Perfect. Thank you so much, Felicia. And I will say, although they are not able to join today, we also put up pictures for Ms. Trinita Ashford, who is the Executive Director of Connection Health, and Dr. Andrea Sherrington, who is the Director of the Division of General Internal Medicine and Population Science. And also, Connection Health is actually her baby, and I'll talk to you all a little bit about that in a second. But both of their unwavering dedication and hard work have been instrumental in making today's discussion relevant and pertinent. And so we'll dive right into the UAB and Connection Health partnership that Nadia actually talked about a few minutes ago. Next slide, please. Perfect. So I'll talk a little bit about the how Connection Health got started or established. The partnership began with a funded grant from the American Diabetes Association that aimed to create an effective model for integrating community-based community health worker program with primary care efforts to enhance diabetes health outcomes. The grant was titled Diabetes Connect, and it proposed to develop an interactive mHealth communication system to facilitate secure and efficient information exchange between community health workers and their primary care team. The whole goal or aim of this was to bridge both environments and enable patients to benefit from coordinated efforts. The study was conducted in collaborations with the Congregation of Public Health, which at the time was a local 501c3 organization that was dedicated to promoting health in the surrounding neighborhoods. And Cooper Green Mercy Hospital, which is located in Birmingham. It's Birmingham's public safety net hospital. The integrated mHealth system was centered on the community-based peer support intervention that was originally developed as an intervention and tested by Dr. Andrea Sherrington. So when that funding ended, the community health workers that were integral to the American Diabetes Association grant were faced with some uncertainty about what to do with their future. These dedicated individuals had been trained and certified to deliver health services and resources to the local community and had formed very strong bonds with the participants as well as the study team at UAB. So recognizing the need for ongoing support and training, Dr. Sherrington proposed the creation of a local organization to provide these resources. So after meeting with some community leaders, they unanimously agreed to establish a nonprofit organization that empowered community members to actively contribute to the improvement of the everyday lives of the people that are around them. I'm going to hand it off now to Felicia, who will discuss a specific project that would be a really cool thing to talk about.
Thank you so much, Dr. Alan Watts. Yes, just as Dr. Alan Watts discussed, Connection Health was established back in December 2014. And Dr. Andrea Charrington, we owe her a debt of gratitude. She has really been involved in supporting of Connection Health as an organization. And the mission of Connection Health is to connect under-resourced patients and populations in the community to better health through supportive relationships and interventions. And this is done by the engagement of community health workers. And I think everyone is pretty much familiar with what the definition of a community health worker, but just in case, community health workers are frontline public health workers. They're trusted members of the community. They have a unique perspective of the communities that are served. The particular project that I would like to discuss briefly of this synergistic relationship between UAB and Connection Health is the Prevent T2 project. This was a small pilot project that occurred between May 2021 and June 2022. That was in the height of COVID. And it focused on counties in Alabama's Black Belt region. And this region, if you are familiar with anything about the Black Belt area in Alabama, high diabetes risk and significant health disparities in this area. So the project is a prime example of a partnership between community-based organization and academia that's deeply embedded in community and ensuring that there are improved health outcomes. So Connection Health, it was the administrative base for the peer coaches and community health workers, and they delivered the diabetes self-management education and support services to the community. It was to serve a cohort of about 100 participants. And this intervention utilized a digital health approach where the clients were provided with cell phones, tablets, digital scales. And this technology allowed the peer coaches and the coordinators to remotely monitor and track the participants' health data. This was pretty important because this was during COVID and we still maintained engagement over this 12-month period with the cohort. The partnership leveraged the unique strengths of both organizations. UAB bringing the academic research piece and the expertise, which lended a lot of credibility to the project, but also Connection Health offered trusted community relationships and effective management strategies. So with that, we'll move on to the next slide.
Perfect. Thank you, Ms. Barrow. So how do we maintain these partnerships? I would say that there was a shared vision to improve community health and well-being through the collaborative research and engagement, joint commitment to sustainability of community health worker workforce, alignment of UAB's academic excellence and Connection Health's trusted community presence for a lasting impact. Focusing on developing financially sustainable models for the community health worker employment and support, and as well as ongoing evaluation and adaptation of programs to ensure long-term visibility of community health worker initiatives. Next slide, please.
And with the co-creating of research, we were able to leverage the research infrastructure with UAB, just as we had mentioned before. We combined the grassroots community engagement. And, we were able to integrate some quantitative and qualitative analysis. We used storytelling quite a bit with this partnership, and it fostered a collaborative environment where both organizations contributed at every stage. The research design from that stage to implementation, evaluation, even dissemination. All of those played a big role where we were able to bring that evidence-based solution to best practices to the community. Next slide, please. Now with compensation, because traditional funding models come with many layers of bureaucracy, it was important for the community partners to get what they needed, the support that they needed at the time that it was needed. So through Connection Health, we were able to tailor the project budget to ensure that the support was meaningful and impactful. There was, because of a community-based organization and our structure, we could bypass some of those hurdles that are normally experienced with traditional funding models. When it comes to the engagement with community health workers, we used a hybrid approach. The community health workers were both employed as staff, and they were serving as independent contractors as well. So we wanted to make sure we had the flexibility to have the right people in the right place without getting bogged down in a rigid hiring practice. So we thank you so much for allowing this opportunity to talk about this. I'm trying to go through this quickly, but we'll go to the next slide.
Perfect. And then this is our last slide. So just some key takeaways And we're happy to answer questions a little bit later, but it does take time to create and establish partnerships. So don't rush the process. So building trust within the community and aligning their goals with your own requires time. And given the lingering mistrust some communities have towards research, it is crucial to be transparent and committed to the hard work that's necessary to foster that relationship between community partnerships and academia. Also, exploring and collaborating on funding sources to help maintain the partnership. Identifying and allocating resources such as funding and personnel is vital for the longevity of these types of partnerships. Dr. Sherrington envisioned Connection Health being a standalone, so not necessarily relying solely on UAB or her. And a prime example of that is 2 years ago, Connection Health got funded $3 million from HRSA to improve and highlight and expand the community health worker workforce. And then lastly, true partnerships are a mutual exchange where both parties give and receive. So as I mentioned, while Dr. Sherrington does bring the academic expertise to the table, she is not the only person at that table. Neither does her voice is it louder or than other people in the board. And so it's important to have everybody come to the table and be able to have shared experiences and to come together and bring those experiences together. So I will conclude with that because I'm pretty sure I'm over time. Thank you all.
Thank you two so much, Felicia and Kristen. That was excellent. I see a question in the Q&A. However, I do think we should keep moving to keep up with time. So feel free to answer that in the Q&A box. It's a question on storytelling, which I think would be great to discuss if we have time at the end, but go ahead and respond to that question in the meantime while we move on to the next case presentation here. So we have Guillermo Alvarez with Latino Health Access. Feel free to give us a little more background on yourself and dive into your presentation. Thank you.
Thank you very much, Dr. Barney. Good afternoon, everybody. My name is Guillermo Alvarez, and I am here representing Latino Health Access. We are a nonprofit organization.
Guillermo, we're having a little trouble hearing you. Your voice is very low.
Is this a little bit better?
That's great. Thank you.
Perfect. I'll work with the mic. All right. Good morning, good afternoon, everyone. My name is Guillermo Alvarez, and I am here representing Latino Health Access. We are a nonprofit organization working alongside the community in Orange County, California, for nearly 33 years in an effort to improve the holistic health. We work with the promotor model, also known as community health workers, in an effort to disseminate culturally and linguistically appropriate information on various health topics such as diabetes, but we also talk about housing, we talk about food accessibility, and we talk about emotional wellness, amongst other topics. Our promotores are experts at onboarding participants in order to assess their individual needs and then connect them to the proper resources throughout the community. We implement something called popular education in order to reach or connect with those hard to reach individuals. But better yet, it also helps us to better understand some of the barriers that the community is being faced with on their daily lives. Next slide, please. Taking a little bit back to who promotores are, or at LHA, what we consider a promotor to be. For us, a promotor could be anybody in the community who is a mom, a dad, anybody who is willing to help and include others in the creation of a healthier space for all. Promotores are also experts at developing relationships, trust-based relationships with communities that eventually open the door for future collaborations. One of the things that I do want to mention is that for us, a promotor does not require a formal degree because they are already experts in their own right. And one of the things, for example, an example of popular education would be going to where the community is in order to provide education, whether this be knocking door to door or walking on the street and finding the paletero, the ice cream man, and providing the information while he's at work. Next slide, please. So our promotores actually lead our diabetes self-management and prevention program. It is a 10-week program that adopts a holistic approach and walking with the participants with the overall goal of helping a participant either decrease their HbA1c or delay the onset of the diagnosis. And we do this by talking about all the topics that you guys see in the purple box. We talk about diabetes, diabetes 101. What is the difference between type 1, type 2, pre-diabetes, gestational diabetes, glucose monitoring, complications of an uncontrolled diabetes, because that is a reality. Nutrition, what can I eat, how you should read the nutrition label, exchanging one meal for another, the importance of exercise, of medication adherence. And this is where we tackle one of the big topics, which is insulin. And then we also talk about emotional wellness. So all of these topics are informed or taught in a popular education, but also in a peer-led dynamics, allowing participants to share their own barriers, their own thoughts, ideologies, but more importantly, their lived experiences. This, in the long run, helps to build a camaraderie and support with the participants and with the promotor themselves. This is very, very important because throughout the 10 weeks, we see that the relationship between promotor and participant develops to where the participant reaches out to the promotor asking for assistance in order to make either lifestyle changes or could reach out with assistance with something that could be a little bit more, we like to call heavy, such as I'm being evicted from my house, I lost my job, I don't have access to food, or I'm suffering through domestic violence, which all of these things are things that could directly or indirectly affect the control of a type 2 diabetes. Next slide, please. So this approach down the line has been very, very effective because it allows participants to build that relationship with the promotores. And like I said, it helps create lifestyle changes. We have had participants come in to the class with an A1C of about 13 or 14. And after the 3 months or the 10 weeks, they leave with an A1C of about 7 or 6. This actually has worked where we collaborated with UCI in order to publish the results of our program in 2015, I believe, and they were published. The other part of why this is beneficial is because we understand that diabetes is a chronic condition. Chronic means there is no cure. Uh, so you could be controlled now, but then something such as a pandemic can come and you might need additional help. So this relationship with the promotor is built, lets the participants know that we're here for them at whatever stage they need us. And we have had participants come back to our program 7, 8, even 10 years after the initial participation because they need our assistance again. But more importantly, this also has opened the door for new opportunities and collaborations. We have taken the program not only to schools to educate the parents, but also with other CBOs organizations. But one of the other doors that has been opened for us is a collaboration in research. Next slide, please. And this collaboration actually started in 2023 in collaboration with UCI Minds in an effort to educate the community, to develop an educational program that will provide training to LHA promotores on Alzheimer's disease and related dementias, early detection, risk reduction, but more importantly, how can we get them involved in ADRD research? It was a simple grant initially because there were small funds, but we went through the process of having the initial conversations, of having those participatory methods. We had listening sessions with the promotores that guided our path, and we realized that there was a lot of things that needed to be done for us to be able to get or increase that participation in research. And it was not just going to be talking to the community about it. As we quickly uncovered, there are multiple factors that depend or that align or that guide our perception of Alzheimer's and dementia, such as age, country of birth, culture, social determinants of health, where we get our information. So this eventually led us to restructure our research and include more of the popular education in the onboarding for the promotores. We realized that we needed to make sure that the promotores felt comfortable talking about this topic so that they in turn could talk to the community and address the barriers that already exist regarding research, such as stigma, misinformation, as well as the social and the structural determinants of health. Next slide. So this actually continued our collaboration, and now we're looking to apply for additional funds to continue collaboration with research and evaluate the feasibility and accessibility of promotor-led educational programs to the Latino community, evaluate the impact of risk satisfaction of early referral to AD and ADRD research, as well as we're trying to include this component into a specific education for our diabetes self-management participants, because we do understand that an uncontrolled diabetes also has a higher risk for Alzheimer's down the line. Next slide, please. So going back into establishing partnerships, what is the main points that can help? Mainly community engagement and trust building. It is very important to have the community's trust, but if you are able to partner with a CBO that already has the community's trust, that would be even better. Include the community's leadership in the decision making from the beginning. Be familiar with the community's cultural humility training. What is acceptable, what isn't within that community. More than anything is how is this going to benefit the community long term? We've heard so many times that programs just come and go and leave the community as it was. So how is this going to benefit the community long term? Transparency and clear communication is always is crucial. Not only the data is how am I going to share the data with you in an accessible manner. Technology is very important, but some of our community members still have low technological literacy levels. Some of them don't have access to internet, so just be mindful of that. Flexible and inclusive funding, as it was mentioned earlier, right? We have to compensate our community members for their time. Next slide. When it comes to co-creating research, have it be community center, right? Participatory methods. What is important to the community? If we address what is urgent, what is important to them, they'll take ownership and more likely to participate and respond positively. Build and maintain trust, share power in the decision making. That is very important. All of us bring something to the table and we have to honor that. Let me see. I'm just trying to skip it so I'm running through time. More than anything, one of the things, like I mentioned, is how can these partnerships become continuous and not just have it be a one-off project, because that is something that we hear a lot within the community. Next slide. Be transparent, be upfront with the community when it comes to payment. What are the expectations? And try and steer clear of words such as stipend and honorariums, as sometimes the community doesn't know those words or has different misconceptions of them. Document respectfully and ethically. Minimize. We see a community does not like to give out information, so we have to be respectful. So how can we approach this in the minimal information necessary but get what I need? Last slide, and then this will be my last slide right now, which would be what are the takeaways? Trust is the foundation of anything, whether it's with the community or with partners. Be sure culturally responsive and respectful to the community. Participants must feel valuable. Representation and visibility does matter. Ownership of the community helps. Participation should lead to action more than anything. How can this research or how will this help the community? And be flexible and be respectful and always. Thank you very much.
Great. Thank you so much, Guillermo. That was really terrific. That's nice to see Latino Health Access vigor in your community partnership with research. So please type questions for that talk into the Q&A, and we'll hopefully get to them in the end. Feel free to respond to them in the meantime, though, Guillermo. And we'll move on to the next, Dr. Lu Hu with NYU Langone Health.
Thank you, Dr. Broadney. Good afternoon, everyone. My name is Lu Hu. I'm an assistant professor at NYU Grossman School of Medicine, NYU Langone Health. My research focuses on developing and testing culturally and linguistically tailored diabetes management and prevention interventions among limited English proficient Chinese immigrants in the New York City. So when I'm preparing for this seminar, I think about my journey in the diabetes community engagement research. I feel it all goes back to the very first small pilot mixed method study funded by our very own NYU Center for Study of Asian American Health to try to understand the barriers and facilitators among the Chinese immigrants here. in the New York City when they seeking diabetes care and adherent to diabetes self-management behavior. So based on that pilot, I was very fortunate to receive NIH K99 RO funding to develop and culturally, linguistically tailored diabetes self-management education programs specific for the Chinese immigrants in the New York City here. And also based on the mixed method funding, we also were very fortunate to receive a pilot funding called Family Pilot RCT from the Albert Einstein P30 Diabetes Center as well to examine a family-based diabetes intervention study. And based on those 3 pilot studies, and right now we are very fortunate to receive some follow-up funding to conduct the full-scale RCT to examine, to expand the intervention in a larger scale RCT study include which focus on diabetes prevention, and then link it IDEA, and then in the INSPIRE, we're trying to expand it in the Hispanic immigrant community in the New York City as well. Next slide, please. So when I thinking back about the partnership, I think my partners really involve community health center, specifically the Charles B. Wang Community Health Center in the New York City here, and then also some small private primary care practice in the Chinatown areas as well in the New York, and also most importantly, my partners also include several community-based organizations, the CBOs, and also some community farms as well, especially for our diabetes prevention trial. We are providing the fresh produce vegetables to our participants. So we are partnering with 2 community farms to address the food insecurity issues among the participants. Next slide, please. So in terms of thinking back, I'm not focused on specific projects, but thinking back over the past 10 years, all of my partnership building and maintaining, I think in terms of establishing partnership, I think it's very hard, especially thinking about 10 years ago when I started as a postdoc, having done no research in this area. I feel most important thing for me is to try to lock on your mentor's door. I think I really give the credits to Dr. Ladian Isnan here as the CEDER MPI, and also with several other colleagues, mentors, Dr. Chow Trin Sheffrin, also Dr. Simona Kwang, Dr. Stella Yi. They all very generous to share their network with us because they have done this work over the past 10 years, 20 years. They already established trusting relationship with those CBOs. So when they send an email introduction, it's very easy for me to follow up, introduce myself, and then those CBO are more likely to how do you say, collect with me or meet with me. So I want to emphasize on that. And also the championship, I also want to emphasize is trying to identify the champions from the community organizations that you are trying to work with or the clinical organizations that you are trying to work with. I think I met a CBO leader during one of the community events. Then she collected me to 5 other CBOs in the different neighborhood so that it quickly expand because she is already have those established relationship with the other CBOs. And then when she was able to introduce me, then the other CBOs are very willing to sit on the table and listen to what my project is about. So I just want to emphasize that. And also is that when establishing partnership, trying to align the research project, like my research project priority with those partner priorities. I think for a diabetes researcher, it's very easy for me to justify because like for many CBO leaders, they themselves or their family members or their friends already affected by type 2 diabetes or pre-diabetes. It's very easy for them to resonate and emphasize, to understand, oh, this is very important for our community. And certainly I want to also stress the importance of co-creating, foster the sense of ownership as well. Sometimes they provide really wonderful feedback in terms of the ideas during the idea conceptualization phases. They talk about, oh, I saw so many clients on at my CBO struggling with this. Can you also incorporate, for example, some mental health, some stress management sessions in your diabetes intervention? Can you do that? And also they provide feedback in terms of the control group design. Can you make the control group a little bit, give a little bit more kind of attention or give a little bit more intervention to the control group so they that can foster some sense of ownership in the projects as well. And in terms of maintaining partnership, I think it's very important to keep some regular touch bases, whether it's like a quarterly meeting with them or a bi-monthly meeting with them. I think it's very important to provide some updates about the projects, the research project, as well as to hear what are some recent they are working on as a CBO, to hear from them as well, and then host some community forums to report back some interim results or to share back the results we have collected so far as well. And certainly it's definitely very important. As a researcher, we want them to help us, but at the same time, as a CBO, they have different kind of community events happening as well. Some annual gala event and also some festival like a Chinese New Year celebration. So they would appreciate the volunteers at those events or guest speakers at those events as well. And so I usually attend those, or sometimes if I cannot make it, I send one of my team members to attend those events as well. And then lastly, the holiday greetings and small gifts. I think usually during the Christmas time or the Chinese New Year time, we are trying to send some like a $25 kind of gift, coffee mugs or some notebooks to really show our appreciation during this holiday season. Really appreciate for their partnership. I think that really helps. Sometimes when I go to their office, I saw people using those coffee mugs and it keeps reminding the partnership as well. So next slide, please. In terms of co-creating research, I think many of my fellow presenters already emphasized all of these key points in terms of community-based participatory research, trying to involve them in every stage of the project, from the idea conceptualization to grant application, and then to the project planning and etc. to the results dissemination as well. And I think the Dr. Tandon also mentioned the importance of setting up a community advisory board, trying to set a board so that we can have some regular meetings to touch base and to have some updates from each other as well. And then certainly be open to feedback, to some feedback. I think many of my research ideas come from just meeting with those community partners, meeting with those clinical partners. They say, oh, why don't you also do a diabetes prevention effort in this community? Because as you know, diabetes prevention, diabetes rate is so high, or pre-diabetes rate is so high. People really want to learn how to prevent diabetes in the first place. So we have successfully identified some funding mechanism and do a diabetes prevention initiative. And lastly, also want to emphasize the capacity building as well. Some of the CBOs is also interested in applying for state funding or some small foundation funding as well, helping them to learn how to build a budget and how to write the grant for the first time is very important in terms of this co-creating research process. Next slide, please. In terms of logistic for compensation as well, I just also want to emphasize that trying to involve the partners early in the budget phase. How do you say, just ask them. So this is the scope of the project. What do you need to make it happen so that they can come with some budget? And then if necessary, if we need involve some CBO staff effort in terms of leading the community diabetes education or scheduling the sessions or making the space open for the study purposes. Make sure that we are trying to budget for those staff effort as well, and then be creative in terms of compensation as well. Sometimes I understand as a pilot study, we have very limited funding. So think about maybe provide some workshops for those community CBOs, and then be a guest speaker at their community events as their large community events as well. And then we have done this a lot in terms of offering some raffle prizes. We donate those weight scales to the CBOs during their community events. And then sometimes they need volunteers. So sometimes I send my team members to be a volunteer at those community events as well. Last. So some takeaways, I think many of my fellow presenter already share this, is like trust relationship and also trying to involve them in every stage, not just really, oh, recruitment, can you help us? Really trying to involve them in every stage of the research, and definitely mutual benefits, and have the regular communication with them is very key. I think that's it for me. Thank you for your attention.
Wonderful. That was a whirlwind of a wealth of experience and pearls you provided for us, Lou. All right. Please put questions into the Q&A or chat to be running in the background while we have this final presentation from Marilyn Roman, Miami-Dade AHEC.
Thank you, Miranda. Can you hear me okay, everyone? Yes? Okay.
Yes.
Good afternoon. Awesome. Good afternoon. My name is Marilyn Roman. I am the CEO at Miami-Dade Area Health Education Center. We are a non-for-profit organization. Just like everyone else in the community, we use community health workers as our foot on the ground when it comes to any of our program, especially our research program. Next, please. I would like to share with you one of our most important project that we have conducted in the past few years is called Live Healthy Little Havana Diabetes Program. This program spanned over 5 zip codes in the inner city of Miami, where Little Havana, as you could probably get from, is that it's the home to a large number of older adults, primarily from Cuban descent. And these individuals live on a fixed income. And we decided to really focus our research on those individuals that have been recently diagnosed with prediabetes. Either they have the type 1 or type 2 diabetes. And one of the things that we also did was we invited the family members, their caregiver, because it's important that those individuals, especially in the Latin Hispanic community, the wife is usually the one that prepares the meal, and maybe the spouse or the husband is the one that has, the condition. So we also invited their caregiver to be part of this diabetes self-management program. Our key partner is the City of Miami, Department of Health Services, along with the University of Miami Clinical and Translational Science Institute, which they're just probably like maybe 1 to 2 miles away from the little Havana neighborhood. And also one of our other key partners is the Florida Community Health Worker Coalition. Next slide, please. How it all started. So back in 2017, we had the opportunity to work with Health Services Advisory Group. They received CMS funding through the Everyone with Diabetes counts. And they were providing actually free training for community health workers who wanted to be facilitators on the DEEP program, which stands for Diabetes Empowerment and Education Program, by the University of Illinois. So they came down to Miami. They provided training to, I believe, 15 community health workers. And then from there, we really decided, how can we implement, this resource that we just received in our community. And Live Healthy Little Havana was the first community that we actually implemented this program. That happened in 2018, 2019. COVID was very challenging for us due to the fact that, we were enclosed, you know, we were closed. We weren't able to provide these services in person. The one thing we learned from COVID is that a lot of individuals, especially the older population, did not have access to the internet, or they had a very difficult time accessing even virtual classes. So it was very hard for us to, you know, to implement this program during 2020 and 2022. In 22-23, we also received additional funding from a group called Outreach Global Group, and we continue doing um, our research program, but we also open it up to the African American Black community as well. And then in now 2023 through now, we are working very closely also with the University Clinical and Translational Institute. We're actually changing a little bit our research. We're going to start looking a little bit more into social determinants of health and how those SDOH affects diabetes and access to care. Next slide, please. But in the meantime, the University of Miami does also do research with our largest hospital in the United States, the Jackson Memorial Hospital, which is a public hospital. They also utilize some of our CHW to actually provide diabetes self-management to those patients that were diagnosed with uncontrolled diabetes. And the result of that finding was that CHW does improve A1C, and they also increase access to healthcare. Next slide, please. So what curriculum we use was, like I mentioned, the Diabetes Empowerment Education Program. You know, before deciding on this curriculum, we did test out other curriculums, and we felt that this curriculum was the one that really resonated with our Hispanic and African American community. It's delivered in a series of 6-week session. We spend 2 hours with these individuals as well as their caregiver, and we actually go through the process of understanding diabetes, how to manage their blood sugar, the importance of eating healthy, the importance of physical activities. Each of these activities is very hands-on. For example, when it comes to the healthy eating, we have different menus that they could relate to. I think we have over 500 menus, and they're able to choose what they want, their meal for the day, from breakfast to lunch to dinner to snacks. And then we give them bins of salt, sugar, and lard, and they're able to read their food labels. They're able to convert those food labels into teaspoons of sugar, teaspoon of salt. And at the end of the day, they end up with a full plate full of sugar, and they're able to actually make that connection. So the curriculum we use, we love it, we know it works, and the patient love it as well. Next slide, please. So during this years, we do collect a lot of information, a lot of data. As soon as the individual comes into our diabetes self-management, the first thing they do is complete all their data information. They consent to being part of the program and part of the research, and they also do a pre-test. The two focus area, you know, for diabetes is, does the patient really understand, you know, the disease and how to treat it? And then the second component is the importance of health literacy. Did that patient, did that participant understand, and do they know how to use the information that they receive to make informed decisions about their health? So as you can see, the health literacy um, post-test results, they were 94% of the participant did increase, and they understand how to use that health information to make informed decision. And as you can see in the second, statistic on the importance of disease identification and treatment, it was 78% understood and their treatment and their disease. Next slide, please. So best practice, establishing and maintaining partnerships. So I did something very overview, because we had 3 to 4 different projects going on at different times. And I think some of the most important thing in establishing partnership, and I put myself as a community, of course, community partners, but also using the head of a researcher, is, you know, really identify those zip code with high prevalence. You know, our relationship with the Florida Community Health Worker Coalition is that we could call them up and say, you know what, we want to implement diabetes, in the zip code. Can you please connect me to your CHWs? The foot on the ground, CHW in that zip code. Those CHW will also connect us to other CBOs that knows their community, right? That are the champion in those communities. And once we identify that, then the next step is to really start creating that partnership, to really start creating that trust. And part of creating that trust is, make sure that there's that open communication, those regular meetings, make sure that everyone understand what is the shared vision and what is the shared goals, and also discuss what are their responsibilities. Maintaining the partnership, I think the hardest part is establishing it. Maintaining it, I think, is the easiest part. Always having that bi-directional communication channel, evaluating and sharing of experience, sharing of those success stories, and also the importance of adapting to change in the needs. CHWs and those CBOs that are embedded in the community, that are the foot on the ground, they know that community better than anyone else. We need to adapt. We need to listen to what they're experiencing, and they know, because they know what's going on in their community. And also always be there to provide ongoing support and resources. Next slide, please. So when creating best practices for co-creating a research, I think a diverse research team is very important. You need to have those experts, you need to have those research on board, but also those community members, those people that are experiencing diabetes, that caregiver who is living with that patient that has diabetes, the CHW that knows what's happening in that community, and those CBOs that knows what's as well, like the CHW knows what's happening in that community, which this allow for them to share, decision making. I think is important for these members to be part from beginning to end in the research process, as far as creating questions, as far as even creating a flyer to advertise, because they will tell you, you know what, this picture might work and this picture might not work. This language might sound better and this language does not. So they know exactly what's going to attract individuals to be part of this research studies. Also developing strong communication channels and protocols so that everyone on the research team knows what's happening, that would allow for that foster of mutual transparency is very important. And once again, cultivating the discussion about barriers and listening to your partners. Providing training, I believe, is very important and essential when it comes to research and implementing a program. Everyone needs to understand the objective goals and outcomes. Also, CHWs, they need to understand how the program works. I think they should be given, what these are the tools that we're going to use. These are the consent that they need to sign. This is why they need to sign the consent form. The importance of protecting confidentiality training. So training is very important. Also evaluation, and this happened to us, once and twice, the evaluation framework is very important because if I'm collecting data has for my community base, but also the clinic or the university is collecting data for their clinical component, is important for everyone to understand both the clinical component for that evaluation and for that data, and also for that community-based component as well. Next slide, please. So the logistic once again, just giving you an overview of what I think, logistic compensation should look like. Research team, is always based on funding, as well as the time and effort dedicated to the program. But as far as a community-based organization and a partner, I think it's very important to have clear and open communication about contributions and responsibility. Transparency is very important to build a strong foundation. Sometimes what happen, and it's not done intentionally, but sometimes what happens with community-based provider, because the funding is so limited, maybe 10,000, 20,000. Sometimes the community partners has to flow the cost of the program maybe for 9 months to a year, and then we get paid at the end. Those conversations are very important so that the community partner knows, when payments and contributions will be dispersed. As far as compensation for research participant, we do provide gift cards to our participant in our diabetes self-management program. They're spending 6 weeks with us, 2 hours of their week. So we do give gift cards, but the gift card is also based on CHW's recommendation or the CBO's recommendation. For example, I might want to buy gift card for Smith Supermarket. Smith Supermarket is, 10 minutes, 15 minutes away, but that Hispanic, individual prefers to shop at Garcia's supermarket, because that's where they're going to find the fruits and the vegetables and the food that they use. So keeping in mind that when it comes to gift cards, really, talk to your CHW, to your CBO, so they could give you a good idea as to what type of gift cards that community needs, okay? Transportation costs, we're very fortunate that the city of Miami provides free Uber transportation for participants to go to their doctor's visit, to go to the hospital, to attend a self-management program. So make sure that, if you have resources for that, provide that as well. And we always provide a snack, a healthy snack or water at all of our diabetes sensation. Next slide, please. And the key takeaways, everyone mentioned this, I noticed, trust, okay, which is very crucial and is best to achieve, our desired, outcome. Like I mentioned, I think community members should always be involved in all stages of the process, CHWs as well, and be flexible. Listen to those people that are the foot on the ground, because they understand and they know their community. And thank you very much for being here today. Thanks.
Thank you, Marilyn. That is great. That sounds like a wonderful partnership with lots of activity. So formulate your questions, put them in the Q&A if you want. We only have a couple of minutes. I have a handful trying to prioritize. I'll start with you, Marilyn. You mentioned some of the earlier projects were partners with other academic institutions, UIC and University of Michigan, I think. How did those come about? Did you seek the partnership, as in Miami-Dade reached out, or did they seek you all? Do you know?
At least for Miami-Dade, they seeked us out.
Okay.
They knew, we have CHWs, they know our connection with the Florida CHW Coalition, so they seeked us out, yes.
Okay. And proposed, I presume, a project or a concern and asked if you were interested, to join on board. Okay, great. I had a question for Guillermo. Guillermo, hopefully you're still there. One of your slides mentioned cultural humility training. Guillermo, are you with us? And I was wondering if that was in a formal sense that you all have access to that or offer that for various team members who are interested or would benefit. And if Guillermo,
Yeah, no problem. So we actually, one of the departments, my department is one of 8 at the agency. We do have one from our Promotor Learning Institute that is able to provide all of these trainings, right? How to do onboarding, how to outreach into the community. So we do have a department, at least on our end, working with our community, our experiences, that we are able to provide that.
okay, so it sounds as though the curriculum that you're describing is intended for promotores, or is it intended for academicians, from researchers coming into the community, or both?
So it's both. So our Promotor Learning Institute not only works with community members seeking to do promotores, but with also research institutions or with other community organizations that are looking to get involved with promotores. They have done trainings to pharmacies as well, because here one of the things in California that CHW services are being able to be built through Medi-Cal. So we are looking into how we can incorporate promotores into clinical settings, pharmacies, community clinics, right? So we are expanding, our program is expanding into working with researchers and academics and other professionals as well. and highlighting a collaboration with promotores and how that works, how that looks. Yes.
Okay, great. Many of you mentioned champions, needing champions to help you with partnerships and help you run the actual projects. And I heard one or more of you mention that you identified those champions through CHWs as a specific logistical step of how to identify a champion. What are other examples or ways that you've experienced or heard of successfully identifying champions, and or maybe comments on how do you know that that person's going to be a good champion for you?
I think one of my research intern that I work with early on, he know a patient with Chinese patient with type 2 diabetes, so he referred that patient to our very first pilot mixed method study. And then during the process, I conducted the survey with her and I conduct the interview with her. When I interact with her, she already mentioned, oh, I know this CBO and I know that CBO, let me collect you. So during my interaction with that, how do you say, patient participant, I already know that she's willing to do that and she's passionate about doing that as well. So that's my experience.
Okay, great.
I just wanted to add to that and to lift up something Guillermo said. I think before people are CHWs, they're community members, and they're usually community leaders. And so it's really about finding those community leaders. And I don't think it's like necessarily leader with a capital L, it could just be that auntie who lives down the block who is always helping people, and is connected to a lot of different people in a particular zip code or neighborhood. And it's often those folks who become CHWs, but I think it's about, connecting with local organizations and local kind of big L and little L leaders.
Mm-hmm. Okay, great. I have a question in the Q&A box. I am an early stage investigator working with 10 family advisors on a clinical trial to promote optimal use of diabetes technology among historically marginalized youth with type 1. How would you recommend moving from advisors or consultations to more shared governance? This is getting kind of specific. Also, do you have suggestions on engaging more community partners instead of relying primarily on family as partners? Family partners, I guess, patients.
I think, oh, go for it. I can tag on.
Oh, no, I was just going to ask a clarifying question. So by moving from advisors to consultation, do you mean that they are a part of a community advisory board currently, and you want to move past that to something more along the lines of, what do you mean by shared governance?
That's how I would interpret it. I only
Guillermo,
have this block, so I don't know, but that's how I interpret it, is perhaps the current access of or participation of engaged individuals is an advisory board or a consultation relationship, but wanting to move to more of a shared governance, shared decision making.
you go ahead, Guillermo.
Oh, I'm sorry. Is Guillermo gonna take that? I was just gonna say that it's been our experience with in Alabama that community advisory board members also want to come to the table and be a part of the Community Health Worker Coalition. And within that coalition, there are work groups that work on different aspects of advancing the community health worker profession. So I think that's one way we do it in Alabama. We invite them to come once they have served within that role on the advisory board. We want to have them come and join the coalition to help us educate policymakers, inform policies locally, as well as on the state level. So I think that's a way to incorporate members.
Thank you. That's a really great example. We're going to wrap up because I know we're at time. I'm hoping that if you registered, you'll get the contact information of the panelists. If you want to go to the next step slide, Sarah, thank you. There's an evaluation for today's events with the QR code listed there. For T1D researchers in the audience, keep an eye out from NIDDK and other sources for additional learning opportunities in addition to research opportunities that may come in the future. And T2, related researchers and programs, you can always request a CEDER consult as was detailed in the opening slides by Dr. Islam. Thank you to everyone, the panelists. Thank you so much for sharing all of your insight and your perspectives and moving engagement in research on. Take care, everyone.
Thank you, everyone. Have a great day.